Good morning, everyone. At the outset, I'd like to thank the organizers and the chairpersons for this opportunity. In our practice, we often hear these statements. डॉक्टर साहब, पहले मेरा ध्यान लगता था, अब ध्यान नहीं लग रहा, या अब मैं जल्दी थक जाती हूँ, पूरा काम नहीं कर पाती हूँ, या अब मैं चीज़ें रख के भूल जाती हूँ, यादाश्त पहले जैसी नहीं रह गई. And sometimes in OPDs, these are very uncomfortable questions to handle. Sometimes you do not know what to do with these patients. You want to just see if they have a relapse or not, and you want to send them off and see the next patient. What essentially we have here in terms of our discussion are three abstracts. What they do is that essentially they show us the burden of the fatigue or the decreased quality of life that these patients have in their follow-up. And secondly, the amount of cognitive deterioration that they have. What I thought that we should take away from here is the quantum of the problem, the factors associated with it, and if there's an intervention that we can do, and that is what we will focus as we go ahead. So the first abstract that we'll discuss is the long-term longitudinal patterns of patient-reported fatigue after breast cancer. It is a group-based trajectory analysis. So we know that because the number of patients of breast cancer is so large, that even if there's a 20-30% chances of having a severe fatigue on follow-up, there is a large burden of this problem in our OPDs. We know that this problem is multifactorial. As we go ahead in this talk, there are a number of factors that may contribute to it, and it is multidimensional. So it is not only a physical problem, it is an emotional problem, it is a cognitive problem, and each of them can have their own contributing factors. So this trial essentially draws itself from the data of the Canto cohort data. It is essentially a French data cohort. In these, all patients, female patients with breast cancers are enrolled. They are of stages 1 to 3, and they are followed up longitudinally. The data collected here is at the baseline 1, 2, and 4 years of follow-up. Patients who recur, have death, or are lost to follow-up, they have a termination in the study. And we have collected both the outcome as well as exposure-based variables. We'll discuss this subsequently. What the study does essentially is that based on modeling, it draws such trajectory groups. In fact, it draws what proportion of patients would be high risk of fatigue, intermediate risk of fatigue, low risk of fatigue. So that is how we'll see things. The primary outcome that we are looking at is the global fatigue score. It is based on the EORTC quality of life C30 questionnaire. The secondary outcome is the other dimensions of fatigue. It could be physical, emotive, cognitive, and so on. The exposure variables here are age, smoking, obesity, anxiety, depression, and treatment-related factors. So what we have is that in the severe global fatigue score, almost 60% of the patient do well. So that is something that we need to pat our backs with. But almost 40% of these patients will have fatigue. In patients who have high risk of fatigue, at 1 year and 4 years, these scores would remain high. In patients who have a deteriorating group, there the proportion of patients with fatigue score increases, and essentially due to use of endocrine therapy and obesity, smoking, these are the factors associated with. So what leads to this high global fatigue scores are, one is age. So younger age people have higher chances of fatigue. Counterintuitive but true. People who are single, who use tobacco, smoke, are obese, have comorbidities, have anxiety, depression, insomnia, are patients who have poor quality of life, as we see later, as well as higher chances of fatigue. In terms of the three subtypes, the physical fatigue, the emotional, and the cognitive factors of fatigue, we see that as seen earlier, there will be around 36% of patients who will have a high chances of fatigue. Some of them will have this problem continuously till 4 years, and some of them will have these new onset problems. Large chunk of them, as we had discussed earlier, are patients who are either on hormonal therapy or ongoing therapy, or are obese or smokers. Similarly, for cognitive factors, there are only two groups, and there are almost 20% of these patients who have a high cognitive fatigue. So these problems that we often face in our OPDs, thak jati hu, yaad nahi rehta, are probably contributed by these. So we see that in terms of the physical domain, the causes of fatigue remain same as we had seen earlier: comorbidities, obesity, smoking, etc. In the emotional spectrum, depression, anxiety contribute majoritively, and the cognitive part, it is the age, smoking, and education that are more important. So fatigue is a common issue in patients who are treated with breast cancer. Some factors are associated with high risk or deteriorating risk of fatigue, which are reversible. And if we identify these problems, we can treat our patients better. The second abstract that we see deals with the same study, but looks at the quality of life of patients who have been treated with adjuvant chemotherapy. The methodology almost remains the same. So it draws from the CANTO trial. It assesses the quality of life at baseline 1 to 4 years, and the outcome variables and exposure variables were measured. Here the outcome variable was the EORTC quality of life questionnaire, and the higher score of course represented a better quality of life. The exposure factors that we were seeing is almost a overlap here. So body mass index, comorbidities, smoking, alcohol use were factors that were studied, and other treatment related factors. So what we get in this subgroup is 4 type of people, or 4 trajectory subgroup. Almost 83% of them are doing well, so they have good quality of life, again a pat on our back. Almost 16% of them have a poor quality of life, 6 of them do poor throughout, and almost 10% of them worsen over a period of time. And as we had seen earlier, a large chunk of these patients are those who are on hormonal therapy and they are having issues based on that. Others are smokers or obese people who are facing problems secondary to it. So the essential associations that we see is that of obesity. So fat people like me do poorly post chemotherapy. People who have comorbidities, who have low monthly income, who are insufficiently active, smokers, endocrine therapy, they have a poorer quality of, or they have a more association with poorer quality of life. We see that a small significant proportion of these patients treated with cancer have poor quality of life. Some of these factors that are associated with it are reversible, and hence we can identify these factors, treat and give our patients better quality of life. The limitation essentially with this study is that we know that CANTO is a longitudinal trial, predominantly takes into account the French population, patients who are reporting to the longitudinal study, and therefore it excludes certain people who are of deprived sections, but I think overall it solves our purpose well. The last abstract here is the cognitive impairment data from the RX Ponder trial. So it looks at 2 essential things. One, based on what happens, who does poor in terms of cognitive function, people who are treated with chemotherapy followed by endocrine therapy or endocrine therapy alone, and who do better, premenopausal or postmenopausal. So this is the question that we are addressing. We know that RX Ponder essentially was the trial to look for the utility of the oncotype DX in patients with node positive disease. So here we are looking at a sub-study of this larger study. We see 2 findings that we want to note here. Premenopausal women who are treated with chemotherapy plus endocrine therapy, their cognitive function decline at 6 months. They are low at 12 months, but they also remain low at 36 months, and it does not matter if these patients treated with chemotherapy plus endocrine therapy are premenopausal or postmenopausal. Women treated with endocrine therapy alone, they have a deterioration in quality of life at 6 months and 12 months, but then this deterioration in cognitive function, comes back to normal. So concluding, a chemotherapy plus endocrine therapy combination has a poorer outcome on the cognitive functions of an individual as compared to endocrine therapy alone. That patients who are treated with this combination have a sustained poorer cognitive function. With this thought, I like to end. Thank you very much.